Since NAF's inception in 2006, I have seen NAF grow from a conceptual design that was of our president, Dominic Spadafora, to really a nationally recognized force of information. We have held conferences in many places already: Sacramento, San Francisco, Arizona, and now twice in LA. And now we're making it possible to reach people from the comfort of their own living room or family room, or who knows, maybe the local bar. I currently sit on the board of NAF as its secretary, and although I'm retired, can we hear it for the retired right now? I have a long executive career in regulatory government in the health field, so I've been very happy to have served on this board. Now let me take a moment to do some housekeeping. If I can get you to open up your programs. I have to tell you that one of the 10 o'clock presentations, has everybody flipped to the exhibitor's schedule and agenda? Dr. Baydon has had a family emergency and he won't be able to join us this morning. In the afternoon, just take a look at the 3 o'clock time slot. We're switching a couple of the speakers. Dr. Levine will speak at 3 instead of 3:30. You can just make a little notation. Dr. Harrison will then speak at 3:30 instead of 3. And just for your information, Dr. Katz is going to be speaking exclusively on MMN, and those are the only changes today. I need to take care of a little housekeeping. For those of you who didn't notice as you walked in the room, this is the most important announcement. The restrooms are right across the hall. We're going to have a break at 11:30. I need you to vacate the room because they will be setting up for lunch, and I want you to use this as an opportunity to, again, visit the exhibitors. And we also have a silent auction in the back of the room. I would encourage you to see the contributions that have been made to NAF and make a generous donation to the things that have been provided. And I want you to look at the exhibitors and schedule page and note all of the wonderful exhibitors and the sponsors that we have for being able to put this program on today. We do have incredible information for you today and no scams. And it's going to be on the latest research and treatments, as well as we even have a section on how to go into deep sleep or sleeping disorders. And we've even thrown a speaker in today that's going to provide us with some great humor to try to lighten our load. What I want to take note is this is what's really important. Sir Francis Bacon said in 1597, "Knowledge is power." So today is packed with information that is being provided by experts in their field. So let's begin to embrace what will be your newfound power to manage your health in partnership with your provider and healthcare system. So with that, I want to welcome our first speaker, Dr. Richard Lewis. As you can see from the PowerPoint presentation, he is director of the EMG laboratory and co-director of the Neuromuscular Clinic in Cedars-Sinai Department of Neurology at Cedars-Sinai. He is board certified in neurology, electrodiagnostics, and psychiatric medicine. Dr. Lewis's research and clinical focus is on neuromuscular disease, including inflammatory neuropathies, myasthenia gravis, gene therapy for motor neuron diseases, and muscular dystrophy. He is well known for his expertise in caring for and developing new diagnostic and treatment approaches to neuromuscular disorders, including ALS. He has earned worldwide recognition for his research on Lewis-Summers syndrome, a variant of CIDP, and he's thought of as a long-lasting version of GBS. He is widely published and a frequent lecturer worldwide. So let's welcome Dr. Lewis.
Thank you very much. It's a pleasure to be here. This is the second year I've spoken at this event. The Neuropathy Action Foundation has become a remarkable organization that those of you who belong should be proud of. I think they've been very helpful for patients with neuropathy, and their educational mission has been quite wonderful. We've worked with Dominic on developing an MMN brochure that actually the GBS CIDP Foundation has published with us, and that's been a pleasure to do that with Dominic and your organization. So I don't know how many of you were here last year. For those of you who were, as the great philosopher Yogi Berra used to say, it's deja vu all over again. So you may have recognized some of these slides. But what we're going to talk about today, and I will try to give time for questions, and I don't mind talking about what may be a scam or not a scam in those questions. Just give you my own opinion. We're going to talk about how neurologists deal with neuropathy. And I want to spend, my emphasis is going to be about the fact that my experience is that the patient comes with one perspective, I come with another perspective, and we need to learn to communicate. And I've hopefully gotten better at it over the years, but as you talk to your physicians, I think it's helpful to know where they're coming from and to make sure that you and they are really working together to help you understand your neuropathy and treat it when it can. We'll talk a little bit about treatable neuropathies, and then we'll talk, I'm also going to do a little bit of what Dr. Beydoun was going to do, and we will talk about some of the treatments for neuropathy relatively briefly, and hopefully we'll have time for questions, although we started a little late and we have to get out of the room, so we'll see how we work. So, your doctor usually asks about your symptoms first. How did it start? When did it start? Is it chronic or acute? That's the issue we want to know. Did this happen suddenly or is it gradual? Is it still progressing or did it happen a couple of years ago, left you with problems, but it's not continuing to progress? So acute monophasic illness, which is what Guillain-Barré syndrome is, or is it chronic progressive, which CIDP is, and many of the other neuropathies that you people have. So is it progressive, monophasic? Is it relapse? Does it seem to give you a problem? You do okay for a while, and then you get another problem, and it relapses, and maybe you improve, maybe you don't, but then you get another peak of problem periodically. And then we want to know location. Did it begin in your toes? Did it begin in your hands and feet at the same time? Was it all over your body at the same time? Is it sensory or motor? So we also want to understand which nerves are being involved. Was it one side or another? Is it symmetric or asymmetric? Most of the neuropathies tend to be distal, start in the toes and gradually progress up the feet. And when the numbness and pins and needles gets to about the knees, the fingertips start to go, what we call length-dependent neuropathies, because nerve fibers, the longest nerve fibers go from your spinal canal in your back, low back, to your tips of your toes, a good 3 feet or so. The shortest one would go from your spinal cord to the back muscles, or the back skin, only a few inches. The longer the nerve fiber, the more likely it is to get damaged in many disorders. And so these are called length-dependent neuropathies. It's the typical neuropathy you see in diabetes. It's probably the most, what we call distal symmetric polyneuropathy. So besides location and the temporal evolution of the neuropathy, we are interested in what your neuropathy is doing to you. Is it numbness? Is it weakness? Is it pain? Do you have some of these other symptoms which people don't always think about as neuropathy, but do you have trouble with perspiration? Do you have trouble with your bowel and bladder? Sexual function? These are autonomic nervous system, meaning that you don't have control of it. You can control your muscles. You can make them contract or not. But these other things are automatic and they're out of voluntary control. But these sometimes can be part of neuropathy. So some of you are old enough, in fact, most of you are old enough to have seen this movie. But the famous line in this, that there is a failure to communicate, I think is apropos to the doctor-physician, doctor-patient experience. So we don't always talk the same language. So many of my patients tell me that they're numb. What I mean by numb, when I hear numb, it means that you don't feel things well, and it also means that you have pins and needles sensation, what we call paresthesias. Many of my patients say numb when they say, well, my muscles, my hand doesn't work right. It doesn't function right. So they equate numbness with weakness or dysfunction. And I try to tease that out because it's important for me to know, is it your motor nerves involved or just your sensory nerves or a mixture of both? The patient frequently wants to impress me how terrible their situation is. I am miserable. It's getting progressively worse. I know it's getting progressively worse. It hurts more. And I'm sure that's true. But hurting more doesn't necessarily mean the neuropathy is getting worse. There's tons of things that make pain worse. Is your sleep worse? Are you more depressed? Is there more stresses in your life? And maybe your neuropathy is getting worse. But for a neurologist, what tells me that the neuropathy is worse is that areas that weren't numb and painful are now numb and painful. Muscles that were strong are now getting weak. To me, that's the red flag of, boy, that neuropathy is getting worse. The fact that the pain in your feet is an 8 rather than a 5 out of a scale of 10 means that you're having more pain, but doesn't necessarily mean that you're having more neuropathy. You come to me wanting me to fix you now. I know that the fix isn't so quick most of the time. And so we need to kind of come to grips with your expectations and my sense of reality. One of the things, we have a inherited neuropathy clinic, a CMT clinic at Cedars-Sinai, now a Center of Excellence for the CMT Association. The first patient I saw in California with the disease was a 12-year-old that was just diagnosed somewhere else, and it was a very anxious family. And in the first 3 minutes, I told the family, your son is going to walk the rest of his life. He may need braces, he may need a cane, but he's going to walk. The air just opened up. The bubble burst, and that's all they needed. They could have walked out of the room then, and they would have been happy. Because they came to me thinking, I have neuropathy, I'm going to be paralyzed. I'm having neuropathy, I'm going to be in a wheelchair. I can't say it never happens, but most of the time it doesn't happen. And so getting those fears out, letting your doctor know what your fears are, what your fantasies, as my wife would call them, of what things you think is going to happen. My wife's a psychologist, so fantasy is a psychology word. That letting your doctor know what your fears are and letting him discuss that with you, I think will be very helpful to you when you do that. So a few other communication mismatches. People want cures. I want this to go away. And what I know is many times I can't make it go away, but we may be able to control it. Most diseases we don't get rid of. You can get rid of your appendix, you can get rid of your gallbladder. Surgeons are great at getting rid of things. But you don't get rid of diabetes unless you get a pancreatic transplant. You don't get rid of hypertension unless you happen to have a surgically caused like your renal arteries are stenosis and they open them up or something. Most medical diseases, most things you see for an internist are controlled, treated medically, but you don't get rid of them. And pretty much the same thing is true with many neuropathies. Not all, sometimes we have some. We've had patients go, about 20% of patients have a 5-year remission or cure with CIDP, according to our studies that Ken Gorson and we did. But it's not the majority of patients. The expectation and the desire of the patient who comes to my office in braces, I want to get out of those braces. That's your job, doc. Get me out of braces. The reality is, in most things that we can treat, like CIDP, the things that are worst get better last. The things that are mild get better first. So when I treat you with corticosteroids or IVIG or whatever treatment I give for the CIDP, I'm looking at those shoulder muscles that are partially weak but not terribly weak, because that tells me that the treatment's working. I also know if you have severe atrophy, shrinkage of those muscles, there may be so much damage that even if I cured the disease, even if I took out that CIDP like a surgeon does, those muscles are not going to get better. And so you need realistic expectations, and your doctor needs to give you those realistic expectations. And I think that in the end is going to help the work, and in some ways I think is going to help the treatment a lot. Because if I gave you the IVIG and you expected that to get out of the braces in 3 months, I get a call, this isn't working. This treatment stinks. And the fact is, it may have worked because all of a sudden your shoulders are better. Or you got out of a chair a little easier because those proximal muscles of your legs actually did improve. So that's why we need to have any treatment. This isn't just for neuropathy. Any treatment, you and your doctor should have a contract. I'm giving you this, and these are our expectations. This is what I'm looking for. And so then you can call back in a few days or a few weeks and say, treatment hasn't done what we thought it was. Maybe it's doing a little bit, but at least you know what to look for. Some of the terms we use, it's sometimes my patients get angry with me because I seem to try to pull out what you mean, and I think you look at me as if I'm confronting you. It's not a confrontation. But when you say you're weak, sometimes people say weak when what they mean is, I get fatigued. And fatigue is an amazing, confusing term. Is fatigue sleepiness, or is it muscle fatigue where your muscles actually get heavy and you can't do things? Weakness to a neurologist is you're pretty weak from the beginning. Yes, you can have exercise intolerance, but it's not exactly the same thing as weakness. It's it's related. So there are a number of other things that we ask, and there's a reason for it. We need to know what other disorders you have. Do you have diabetes? Do you have kidney disease, because they are associated with neuropathy? Do you have anemia? Maybe you have pernicious anemia, and B12 deficiency is partly what's causing your neuropathy. So we need to know a lot about you. A lot of family secrets, if you want to give us to. But family history is very important because I won't say it's the second most common, that probably is a misnomer, but it's because the second most common, diabetes is the most common cause of neuropathy in the world. Second most common is probably leprosy, particularly if you're in Brazil or India. Third most common cause is we're not smart enough to know the answer, what we call idiopathic. But family inherited neuropathy is probably fourth, probably be higher than the inflammatory neuropathies even as a group. So CMT, Charcot-Marie tooth disease, is not a dental disease, is about 1 in 2,500 births have CMT. We now have about 79 genes that we know cause pretty much a very similar phenotype. And we don't have good treatments for it, but we're working on it. There is a consortium of centers around the world, and we're one of them, that are looking into the natural history, treatments, and there have been a few treatment trials. We also need to know about nutrition and medications because they can cause neuropathy. So, let me make sure about time. So, my wife once brought one of her fairly disturbed, psychiatrically disturbed patients to me because she had neuropathic symptoms. And she needed to accompany her because she needed the support. It's a long story. But my wife saw me take off the woman's shoes and her socks and start playing with her feet. And my wife said, "Ooh, that's how you spend your days, playing with people's feet?" And the answer is neuropathy doctors do play with people's feet. And there's a lot we can learn from it, but as I said, many neuropathies begin in the toes and feet, and therefore we really need to understand the feet. And many of your symptoms are in your feet. Most patients with painful neuropathy, a majority of their pain is in their feet, sometimes in their hands too, but majority of it is in the feet. So there's a number of things we need to do in the feet to kind of understand it. We need to understand what they look like. Charcot-Marie tooth disease has a characteristic foot where they have curled toes, hammer toes, and a high arch to the foot, what we call pes cavus. We're concerned about the health of the feet because one of the major morbidities and causes of mortality in peripheral neuropathy is getting ulcerations from not being able to feel things. And so not just diabetics, but anyone with neuropathy needs to carefully look at their feet and maybe want to work with a podiatrist in terms of toenail cutting and other things. So, but we also want to understand the neuropathy, and so testing with the tuning fork and moving your toe up or down and all those weird things your doctor does to you is really trying to understand what nerve fibers are involved. So the tuning fork, vibration sense, and the position are mediated by the largest diameter sensory fibers. The pinprick and temperature are mediated by the smallest diameter. And so we try to figure out which nerve fibers of the sensory system is involved. So neurologists like to have fun, whether they're girls or boys. And so one of our funs is to hit you and scratch you. And we hit you with our big reflex hammer. And if your neurologist taps you with one of those little tomahawk things with the pink head, they're probably not going to find reflexes in neuropathy because neuropathy causes reduced or absent reflexes. And the only way you know that is to hit it hard enough so that you can figure it out. So we hit you, and then we scratch the bottom of your foot sometime, what's called the Babinski sign. Because if your toe goes up like the picture there, and I don't have my, I don't think there's a pointer, but like that, that means that if you have neuropathy, you also have something going on in your central nervous system. So people with brain and spinal cord problems, the central nervous system, have Babinski signs and increased reflexes. People with peripheral nervous system problems, that is from the motor neuron, the nerve, and the muscle, and the skin, that peripheral nervous system part, don't have Babinski signs. The toe doesn't go up when you scratch, it goes down, and your reflexes are diminished or lost. It's one of the reasons why we need to know. Just because you have numbness and tingling and weakness, it could be from the brain and spinal cord. So we need to also make sure that it is in fact neuropathy. The motor system I've just mentioned. If you have atrophy, thinning of your muscle, reduced tone, loss of reflexes, then it means it's a lower motor neuron. If you don't have atrophy, your reflexes are brisk, you have spasticity, then this weakness is from upper motor neuron. A stroke would be a cause of an upper motor neuron problem. Pinching your spinal cord can paralyze you, but it does it on a central basis by paralyzing the central nervous system. If you can bypass it with electrical stimulation to get under where that spinal cord is pinched, things will work fine. So Your favorite test? My actual favorite test, because I do it and I do like to do it, and I think it's incredibly helpful. But yours, facetiously, is your favorite. So why do we do it? We do it because it tells us important things in neuropathy. It tells us what nerves are involved. It tells us whether the sensory system or the motor system is involved. It tells us whether the wire or the axon's involved or the myelin, the insulation, is involved. So it's incredibly important to determine this because there probably are 150 causes of neuropathy, and you don't want to be tested for every one of them. So we need to kind of narrow the focus, and the EMG is one of our best ways of narrowing the focus. EMG is safe. Yes, electrical impulses are painful. They actually are about 1,000th of a second in duration, but you feel it for a second or so. And everyone's different. Some people can't stand electric impulses, and some people don't mind them at all. Dr. Koski, I can shock her all day long. She doesn't care. You know who's most sensitive to nerve conduction tests? Electricians. Electricians will jump off the table before I even get the stimulator close to them. They are so sensitized to electrical shocks that they just can't stand it. It's a problem. The needles are very thin. They're not dangerous. Even people on blood thinners, there's been some studies showing that the blood thinners really don't matter too much. I still don't like to do deep needles when people are on blood thinners, but it can be done relatively safely. But if you're needle phobic, you're not going to like it. And needles are needles, they prick, they hurt. Just a split second. And there are some sensitive parts of the muscle, and we can't always predict. But a good EMG should be able to help you through that, and you should be able to get through the test. So I've mentioned this, and I'm going to skip this because we're running out of time. So nerves conduct normally in the arms at about 50 meters per second, 50 to 60 meters per second. A meter is a yard, so you can see how fast that is. That's how you can say thumb flex, and as soon as it happens before you even say it, because the speed of conduction from the right side of your brain to your left thumb is that quick. Some neuropathies, CIDP, the major form of CMT1A or 1, the conduction velocities can be 20 meters per second, a third of normal, or 10 meters per second. Some forms of CMT, I've had them down as low as 2 meters per second. So it's very slow. When they're that slow, nothing else does it but damage to the myelin. On the other hand, if your conduction velocity is 50 and the amplitude of response is very low, then the probability is, although not definite, but the probability is that the axon or the wire has been destroyed. And what you need to understand, and this is particularly true in CMT, and when we talked about this in February to our CMT patient conference, whether it's the myelin that's the primary cause or the axon. If the axon is destroyed, that's the part that gives you the permanent damage. That's the part that causes the atrophy that may not come back. Now, nerve fibers can regenerate, but not great. It regenerates an inch a month. And so if I cut a nerve fiber here, it's going to take 2 years to get down to here. And by that time, the muscle is no longer receptive. If I cut it here, then there's a good chance it can regenerate as long as I can get that nerve to grow back, which if it's cut, it's hard, but if it's squeezed, it's easier. So carpal tunnel syndrome, even though it can be severe, can recover, where a pinched nerve in your neck that's terribly severe may not recover. There are other ways strength can recover, but we're not going to go into that right now. So, as I mentioned, the axonal ones are more common, but the demyelinating ones tend to be more treatable. So we look for the demyelinating ones because they may be CIDP, they may be GBS, and if it's axonal, then we have to look for alternative explanations. And so the needle part of the EMG, if a muscle is weak, and it's not due to the brain or spinal cord, but due to a lower motor neuron, we can usually tell by the needle whether the damage is to the nerve affecting the muscle, making the muscle weak, or is primarily the muscle. Can't always tell without the needle in there. So muscles, muscular dystrophies, polymyositis, inflammatory muscle disease look entirely different than neuropathy, pinched nerves, ALS on the EMG. And so we use that to figure that out. And I've talked about that. Nerve biopsies. I rarely order a nerve biopsy. I see tons of people with neuropathy. It's very unusual that I order a nerve biopsy, because most of the time it doesn't give you the answer you really want to know. Most of the time, if there is an answer, you find it in other ways. I'm not saying it shouldn't be done, but if your doctor is suggesting a nerve biopsy, you should ask him what it is that's going to tell. Is it going to give us a diagnosis? What diagnoses are you looking for? And if you're still not sure, get another opinion. So there are some things it does do. It does show inflammation of the blood vessels to the nerve, vasculitis, which is treatable. It can show infiltrating diseases. Sometimes cancers infiltrate nerves, and you may want to see that. There's a disorder called amyloidosis that you would see on nerve biopsy. There are some things that have a unique signature on the nerve biopsy. Sausage-shaped changes in the myelin in hereditary neuropathy with liability to pressure palsies is one. And sometimes when there's confusion, sometimes it can tell us, is that myelin really primarily damaged or not? So here are some pictures of it. I'm going to skip that right now because we're running a little bit late. So I want to spend time, this is now Dr. Beydoun's half hour that I'm been going to use. Treatment. It's a contract. You and your doctor need to be on the same wavelength. So here's, you need to know what the short-term expectations of the treatment are in the long term. What am I looking for when I give you a medication? Am I looking for stability so it doesn't get worse? Or am I looking for it to improve? Should I expect improvement in the first week or the first month or the first 3 months? Or is stability a pretty good sign in the first few weeks, and then I should see improvement in 4 months? Am I looking to improve strength, sensation, or pain? What is my treatment going to do? Which one should get better? What is the red flag that it's not working? All these things should be discussed as you get a treatment. So I say this to my patients all the time because this is particularly true in Los Angeles. And I've been here now a year and a half. Doc, I'm not taking medications. So what are you doing? Well, I take all these natural substances. I spend $600 a month on my natural substances. And I say, do they help? Well, I don't know, but they're supposed to help. And I say, well, what's the difference between those and medication? A medication is what you take to make your body better. Some medications have evidence that it works for certain disorders. Some things are thought to, and there's theoretical reasons. A lot of the natural stuff is helping the immune system, whatever that means. And I'm being a little bit cynical, but the reality is we just don't know. So I was at a conference in Bakersfield Saturday, and one of the speakers was an internist who does a lot of natural treatments and homeopathic treatments, and we were talking about it, and she was a very knowledgeable person. We just don't know. She thinks it works, but no one's done the studies to find out. So we talked about maybe we can do a study to find out what works and not. So, but for patients, you need to distinguish between risk and side effects. They're not the same. A side effect is I give you a medication, gabapentin, and you get dizzy and nauseated. or I give you nortriptyline, and you're sleepy the next day, too sleepy. So what are you going to do? Don't take it anymore. You're not dying. You're not nothing. You may have lost 12 hours or 24 hours of where you're not feeling good, but you were giving something that has a potential benefit, and there may or may not be side effects. A risk is I give you the medicine and you can die. That's a concern. Now, it could be a 1 in a million chance you can die, and then you have to weigh it. But if it was a 1 in 2 chance you're going to die, you better have a pretty bad disease to do that. So be careful. Don't dismiss medications because of side effects. Discuss it. But a side effect is something that will go away. A risk is something where you take it and it's going to do permanent harm to you. It's going to throw you in the hospital. You may die, you may get better, but you're never going to be the same. I'm being a little bit exaggerating here, but I think it's important because I hear this all the time, and I think you're doing yourself a disservice by not trying something that has a potential of really helping you, where there's actually evidence that it might help you. So we talked about that. So treatable neuropathies. Many symptoms can be treated. Not all neuropathies can be treated. So there's a difference between symptomatic treatment and treating the disease. So if I give you gabapentin or Neurontin or Lyrica and pregabalin or Cymbalta, which is duloxetine, I'm treating your pain. I'm not doing anything to the neuropathy. So if you have neuropathy and say I have some numbness in my toes, and your doctor gives you gabapentin, if you think it's going to get rid of your neuropathy, it ain't going to do that. It may make your symptoms less painful, more easily livable. Some of the medicines may help you sleep through the night when your major symptoms were keeping you up, but we're not fixing the neuropathy. Fixing the neuropathy is what we hope we do with IVIG and steroids and other treatments for CIDP. Treating the neuropathy would be what we do with B12 when we give it when someone has no B12 in their blood, and we give them B12. We have hopefully stopped that neuropathy and myelopathy, because actually the spinal cord is probably more of a player than that, than the nerve. But so there are different things that we call treatment. So the risk-benefit ratio has to come up. Would you take a medication that has a high risk of hurting you for symptom control, or would you just take ones that have side effects? Depends on how bad your symptom is, right? If your pain was a 12 out of 10, you might say, I'm more willing to try anything. But that has to be discussed. On the other hand, if you had a disease where you were going into a wheelchair, you might take that risk with a serious immunosuppressant, cyclophosphamide, or rituximab for certain treatment disorders. Even though we know there's a risk of getting infections that people have died from with that, or cancer 10, 20 years later. But to keep me out of a wheelchair and allow me to function, it's worth it. So those are the discussions you have to have. So here are some of the treatable neuropathies. These disorders, when you have another disease, the treatment for the neuropathy is treating that disease. Compression is obviously treatable. If you have a carpal tunnel syndrome, that's probably one of the things where the risk of surgery versus the benefit, the risk is very low and the benefit is hugely high. You might want to have that. But I've had patients who said, no way am I ever going to have surgery. And they're miserable with this waking up in the middle of the night with their carpal tunnel syndrome. It's a simple surgery. There's like no morbidity, mortality. I wouldn't say no, but it's like 0.1%. And the chances of being better the next day after the surgery is huge. But they go years without getting the treatment to make them feel better. So you need to know those things. Don't just have an emotional response. Surgery is bad. Homeopathic medicines are good. medicines that your doctor prescribes are almost as bad as surgery. There's some truth and there's not truth. So again, we talked about realistic expectations. Frequently, I tell the patient, you may not notice major benefits for the first few months, but we're going to get you back here and I'm going to see whether things that I notice have improved. That at least tells me there's a biologic effect, and it says, let's give this more time so you actually will notice the difference. I'm going to skip this because Dr. Koski is going to talk about GBS and CIDP. It's a big topic in and of itself. One of the things that's come up, IVIG is a whole issue into itself. It's being used. It is, CIDP is the disorder, more IVIG is used for CIDP than any other diagnosis. And the misdiagnosis of CIDP is quite striking. So many people are getting it, they think they have CIDP and they don't. And their benefit from the IVIG is it gives me more energy. I feel a little bit more comfortable. But it hasn't really treated the disease. If you don't have a side effect from IVIG, or don't have a stroke, because IVIG does have risks, you can get blood clots in your veins and in your arteries, and it's not the safest drug in the world. It's pretty safe, but it has a risk, small but real. Everyone who doesn't have a side effect like headache and nausea and allergic reactions or a bad vent will feel more energy. If I had IVIG, I don't have CIDP, I don't have a disease that CIDP will fix. If I get IVIG, I'm likely to feel more energetic. Not sure that's worth taking it. Our health system would go under if everyone took IVIG at doses that helped energy. And there wouldn't be the IVIG out there for people who really do need it. So just be aware of that. Pain, how am I doing with time here? A little bit, not too bad. Pain is complicated. Your feet hurt, but where do you actually register that pain? Pain is in the brain, okay? So sometimes we can help pain in the feet by getting rid of the initiating factor, which is whatever's going on in the nerves. So lidoderm patches sometimes work because you're numbing up the nerves that have sent the signal. Sometimes capsaicin, which is the hot pepper cream, can make things better if it doesn't burn, make you feel like and don't stick your finger in your eye afterwards because you'll get hot pepper in your eye. But so sometimes treating the initiating problem can occur. But many of you who have terrible pain in your feet want them chopped off. Then you get phantom limb pain. Your foot will still hurt because your brain thinks your foot's still there because the nerves that are from your foot, they're still in your leg going up to your spinal cord. So there are a number of factors that mediate pain. One of them is sleep, and I'm very glad that you're having a sleep talk here because if you don't sleep, you're going to hurt. And if you have pain at night, you don't sleep. So one of the factors of what medication to use is how bad's your sleep, because I might try to find one that helps pain and sleep. So the tricyclics like amitriptyline and nortriptyline are particularly very good at that, okay? But there are other ones that like gabapentin, which may not make you sleepy. So that may not be the best one at night. So that's one thing. The other thing is emotions. So the emotions and pain are connected. They have the same neurochemical mediators, the serotonin norepinephrine pathways. They have, and there aren't many people in pain who are happy, and there are not many people who, if you're more likely to have pain if you're depressed, and it becomes a bad circle, and you don't sleep if you're depressed. So you get into this vicious cycle of pain, sleep, depression that all plays a role. And so the medications, not surprisingly, that work on neuropathic pain, what do they work on? Depression. What's the other one they work on is actually seizures, because the electrical system in the brain is similar to it affects pain in the same similar ways. So most of the neuropathic pain medicines are related to antidepressant and to seizures. So your doctor sometimes will say, you know, your emotional issues here are important. We need to treat that. So sometimes I say that. Maybe I don't say it the right way. But the first thing, he thinks it's in my head. He doesn't believe me. He doesn't think I'm really in pain. He doesn't think I have neuropathy. And the answer is, I know you have neuropathy. I know you have pain. It's your pain. I can't say you don't have pain. I mean, any doctor who says you don't have pain doesn't seem to, it's a subjective, it's your pain. Any more than I know whether your pain is going to be better, only you can tell me if your pain's better. So that has to be all discussed, but you do need to deal with the emotional things. And so some of these things like meditation, these mind-body things, stress management centers, have a role to play. They're not scams, they actually do help. There are other things that are a bit scammy, but those aren't. And so here are some of the medicines. Wanted to bring up this. Narcotics for nerve pain. Controversial. 20 years ago, we were told as physicians, you weren't ordering enough narcotics. You were allowing people to be in pain. Now it's the opposite message. You're giving too much narcotics, you're overdoing it, and you're hurting people by giving them too much narcotics. The reality is somewhere in between. Narcotics are thought not to help neuropathic pain. I think that's true. But I do also know people who find narcotics do help their pain significantly. And then you and your doctor have to have this contract. If you want to keep increasing your dose of narcotic, your doctor has to say, nope, we'd use this, and this is as high as we're going. Because there is a point, one of the things about narcotics is they get what's called tolerance, and what works at one point may not work in the future, and you can want more. Those morphine receptors don't respond the way they did before. Short-acting narcotics versus long-acting. I've had a number of people with bad neuropathic pain. A small amount of long-acting narcotics allows them to work and function perfectly well, and I think that's been worth it. So, but you have to figure that out, and you have to work with your doctor carefully on it. But in general, the other thing about any treatment for pain, if it's only getting your pain from a 2 to a 3, it's probably not worth it, or a 3 to a 2. If it's getting it from an 8 to a 7, probably not worth it. You may want to increase your dose of gabapentin to see if you can get from an 8 to a 4. But if medicine's not working, you and your doctor need to say, we've tried that one, doesn't work. But the way you know you've tried it is to increase the dose to where you've given it the best chance to work, and you stop when there are side effects or risks getting involved. So we build it up sometimes so you get used to it, make sure that you're not overly sensitive to medicine. But if nortriptyline isn't working at 10, 20 milligrams, it might work at 30, 40, 50, and occasionally even 100 milligrams. Probably don't go much higher than that for pain, but depression, they use 150 milligrams or more. So these are things you and your doctor have to work out. Medical marijuana, we don't know, but people use it, and people seem to respond to it. I think it works on a number of aspects. Whether it directly works on the pain or not, I don't know. But I think it relaxes people and does things that allows the pain to diminish for whatever reason. So I'm not saying you should, but it may be, if you're really struggling, it may be worth doing. Alternative medicine, we talked about this. There has been one study, it's a little controversial, but alpha-lipoic acid is one of the ones that people have used for diabetic neuropathy, and people sometimes find it helpful for the diabetic neuropathic pain. And even though we don't know whether it works for other neuropathic pain in general, neuropathic pain is neuropathic pain to some extent, And so it may be worth a try. The rest of it, I wouldn't overdo vitamins. And the expensive vitamins that you see advertised are expensive vitamins. And you may find that it actually causes problems. So interventional treatments, if you go to a pain center, they will work with you on medications, and good ones will have psychologists to work with you, which I think is helpful. But there is a tendency to want to do interventions. And if you have a focal nerve problem, a nerve block, and those kind of things may be helpful. If you have complex regional pain syndrome, a difficult disorder, sometimes they'll do sympathetic ganglion blocks, which may or may not be helpful. And if you're really miserable in pain, they're going to talk to you about spinal cord stimulators. I can't say that I've had patients who've hit a home run with it, but there are patients who seem to think it helps. So, but that's significant. There are risks, and there are potential issues with that. There are people who are doing brain stimulation to try to overcome pain. Still kind of in early stages to know how much it helps or doesn't help. And on that, and cramps and restless legs. Cramps is a big problem. I used to love giving quinine. It worked great, but the FDA, in its infinite wisdom, decided that the risks were too high for cramps, and so it took it off the market for us, even though the risks are relatively small, but people have died from hemolytic anemias. And so some people go to Canada to get it. Drinking tonic water, some people say it helps. I don't know. You have to drink about 2 gallons of tonic water for every pill. But, you know, if you like your gin and tonics, maybe that's going to work for you. People try all kinds of things. I've heard all stories. Soap in the bottom of my bed helps my nerve pain. Harmless. Go ahead, do it. And if it works, let me know, because I'll tell the next patient. Just tell me what brand, whether it's in the package or not in the package, so we can understand it. But I've heard a lot of different stories, and you'll see those on the internet. Mixilotine is a medication that does help certain types of cramps. It's being tested in ALS cramps right now, but it has its side effects and some risks. It does affect the heart. And restless leg, there are pretty good treatments for. Some of the Parkinson's medicines are quite good for restless legs, so you have that option. And for some reason, our computer is saying it needs to be plugged in. And so I think I'll stop there. And I'm pretty much on time, but yeah. I can have 5 minutes. 5 minutes, we'll start with that, and then ladies first. I think it will affect whether people go into it, but I would say most neurologists, or many neurologists, will still be doing them. EMG, like many things in medicine, have been overused. Their billing system for EMG was not ideal, and so they were kind of cutting their own throats. So I think hopefully they're going to come up to, like everything else, things were too high. They slashed it to where it's unreasonable, and I suspect in the future we're going to come up to something that's more reasonable. Yes? Gentleman behind you, and then, yes.
Are you familiar with laser treatment for neuropathy?
A little familiar. I mean, I'm aware that it's there. There actually is a little bit of science behind laser and light treatment. But whether it actually has helped in patients, in people who have it, it's unclear.
Who does it help? Who does it help?
Well, what I'm saying, there's been some treatments of light therapy and laser therapy in mice and rats that had some suggestion. So it was right. But I'll be honest with you, if the treatments for mice and rats went to people. We all responded as people as much as mice and rats. We would cure all our diseases because mice and rats seem to respond to a lot of stuff. So the answer with laser, we don't know. Yes?
Yeah, there's a couple of major companies that are advertising on TV and all over the place. They use the light. What was interesting, I've gone through that. The computer, if they were to read, look in the computer, it says most of the cases at $10,000 for 10 weeks, nothing's cured. Can we say that's a scam, or there's really not enough research into light there?
I don't know if it's a scam in the sense that they know it doesn't work and they're deliberately doing just to make money, or that they are actually true believers and think they're helping people. That I can't tell you their motivation. What I can tell you, and this is true in neuropathy, and I've seen the 2-page ads in the LA Times for both chiropractic treatments and for get all your nerves cut in your feet and your legs, and that's going to help your neuropathy, is that what it's saying, and it's very clear to me, and I understand this, there are many people out there with nerve pain, and we in the medical profession really don't have good enough treatments. And so what these advertisements are is recognizing that there are people out there who are pretty miserable, pretty desperate, and are willing to try anything. And if they have the money, they're willing to pay it. I would hope, and there's a neuromuscular blog, I don't know, Lee, I don't know if you're on Rick Barron's, but there's a whole thing now about people with ALS going all over the world for stem cells. Can you blame them? I don't have a treatment for them. So I understand where the need is and the desire of the patients to come, and I also have some idea of where the people who are giving it think they're coming from. But, and I know of some people who have the same therapy ideas who are not necessarily making money on it. They just think there's a belief. There was a thing on the TV. I think it was on Jon Stewart about something. It was where this woman said, I know there's evidence like for global warming, but I have my own evidence. I know what I believe in. I don't think it was on global warming, but it was something similar. People have this idea that what you believe is evidence. It's not. It's just a belief. So there's all this that goes into all this. So it's a little bit of a preach, and I apologize. So, yes. I'm going to answer very briefly and let Dr. Koski answer. The answer is stress affects symptoms, but the CIDP is not caused by stress. So you will feel worse. It's not clear that the disease would progress because you're more stressed, but you will certainly feel worse. What causes CIDP is something that is being investigated. It's a difficult question. Anyone else? Well, thank you very much.